Strachan, and today I'm going to present on crisis intervention for patients with mental health. Specifically, I'm going to present with a bit of a disaster context to it, and I'm going to outline nursing interventions, de-escalation techniques, a little bit of triage as well, and some other considerations, particularly in a disaster context. The main reason I've chosen this topic today is the organisation I work for. One of the things that we do is we actually provide support for health and wellbeing for patients after a disaster, natural or otherwise. The Australian Institute of Health and Welfare's report by Gaskin in 2012 highlighted that 80% of patients between 2012 and 2013 reported to an emergency department or an outpatient environment for their principal diagnosis, and most of those diagnoses were around stress-related incidents. So what is a mental health crisis? A mental health crisis, outlined by Stewart in 2012, was any stressful event that exceeds a person's ability to cope with it ongoingly. That can be a maturational crisis, so something that's occurring over the time of someone's life, whether that's a transition from adulthood to from youth to adulthood, or to parenthood, or marriage. But it can also be situational, so something that's unexpected as a stressor, whether that's marital crisis, loss of a loved one, or a natural disaster. And Algeria in 2012 argues that not every event that a patient experiences that's maturational or situational will actually result in a crisis, but it depends upon a patient's ability to cope, what they've experienced in the past, and their support mechanisms. So most patients start at a level of homeostasis. We all have a level of stress in our lives that we're able to cope with our own skills. We then progress to a stage when we get a stressor that's bigger than that, to what we call disequilibrium, whereby we need to develop new strategies to cope with this bigger stressor. If we're able to do that, we go back to homeostasis. If we can't, that's when we go into a crisis and we have those high levels of panic and anxiety and unable to function normally. Disaster crisis. The difference here in this context is that there are other things to consider. So the intensity of the impact, the amount of the community that is affected, the potential for the hazard to reoccur, so for that tsunami or that bushfire to recommence, whether some cultural aspects have been damaged in the process, so whether the tsunami may be associated with some religious thing that's going on, and the number of people that have been lost. So was there a large number of loss of life? Was there a large number of community resources? Do we no longer have a home and a place to call to be safe? And so Maslow's hierarchy of needs disappear in a disaster situation. And there are three general phases. So there's the emergency phase, there's the early impact phase, so sort of up to the 8 weeks afterwards, and the restoration phase. At any time along this continuum, a patient can present with a mental health condition associated with that disaster. So what is crisis intervention in this context? Crisis intervention is meant to be a brief and timely focused support to get the patient who is maladaptive to cope with that stressful event and to get them back to their pre-crisis level. So that's to provide them with techniques that are patient-driven and patient-focused to being able to support themselves ongoingly. In the context of disaster, that actually starts at the very beginning of when the incident occurs. So our role as a healthcare worker in that environment is first of all to protect the member, so to take them away from the incident, to no longer have them exposed to that particular disaster, to direct them to where is safe and where they are going to be able to physically be safe and therefore reducing that mental stress, and then to connect them. So that's for us to provide a personal connection and a sense of normality, that there is going to be hopefully a light at the end of the tunnel, a positive outcome, but also then to connect them with loved ones and to provide them information. De-escalation strategies in that first contact with the patient. These were highlighted by New South Wales Mental Health Drug and Alcohol Office in 2015. They're very simple techniques that can help calm a situation, and you should use them with all patient interactions, not necessarily just with mental health, but they're essential with mental health. So introduce yourself, and again, begin that rapport at that point. Be calm and courteous with your approach to the patient. But normalise the concept. Treat their mental health condition as though they have an actual physical condition, because sometimes that can be a factor that they don't feel like you believe it's real. Inform the patient and the family of what's going on with waiting times. Everyone in an emergency environment are very perceptive about their needs and about getting looked after. So if you let them know why there's timing delays, they feel like they've had a patient interaction with a nurse, and that counts in their sense of being treated. Listen and talk to the patient, and always explain actions that you're doing, whether you're moving them, why you're taking bloods, what's going on. Anticipate their needs in terms of just their basic needs of sleep, respiration, food, water. Even though these patients aren't, in an acute infectious stage, they need all this support because their body is still under stress, it's still fighting off an infection, so to speak. And involve trusted other ones. This may not be loved ones and family, it might actually be a friend or a mentor, someone else around them that they actually trust in this situation. SAVED is a tool that was developed by New South Wales Health in 2009 and has been reviewed in 2015. It's been used in a lot of emergency departments as a way of giving a holistic approach to mental health and mental health conditions and supporting them during that crisis intervention phase. So first consideration is safety to yourself, the patient, to others, and what are the risk factors associated with looking after that patient. Where are you doing the assessment? Do you need to make sure that you're in a safe environment? Do you need assessment phase? That is a part that both mental health workers, nurses and doctors all interact with. So that's doing a mental status assessment, and again always reassessing the risk factors as you go along when you're looking at behavioural disturbances that are occurring. But then also looking at holistically their health condition, their life situation, what else is going on around them. Then confirming diagnosis. This is done mostly by the doctor. However, we can support that by doing bloods, blood work, x-rays, those sorts of things, and try and look at ruling out a differential diagnosis on a biological background. Then we consult. So this is something, again, the doctor may consult the mental health team. We might also interact with community services. So the next part of the tool is immediate treatment. And again, some of these things can happen in a parallel to the other things at the same time. So that may be giving them a place to sleep and to rest and taking away those general pressures in their life to make things a little bit more comfortable so we can focus on developing some more adaptive strategies. And then transfer of care. So anybody that has self-harmed or is at risk of self-harm who have said that they would self-harm or potentially would back in the community will need a mental health referral and ongoing support to be provided before they get discharged. And these patients are more likely to be admitted as well into the hospital in an ongoing fashion. Other things to consider is, again, the assessment environment, cultural background, what would stress us and what culture may not stress someone else, and vice versa. Language, whether you need a translator. The method of arrival, did they come by ambulance? Did they come willingly? Were they brought in by family and friends? Does that change their behaviour and risk status and their aggression factor? And then our duty of care. Whilst under the Mental Health Act we have a duty of care to provide them support and prevent them from harming themselves or harming others or causing serious harm, that does not mean we can force treatment upon them. There is a distinction there. We are only there at a last stop to prevent harm, not to force treatment, particularly physical treatment. So all of those things are a really good tool to use in a nursing context for crisis intervention. In disaster crisis intervention, the other factors we need to look at is the holistic environment around us. So providing support and reassurance, but things like basic needs and allowing them to grieve loss, giving people personal space, rest. These are things that we may not necessarily think about in a hospital context, but in a disaster context, these are very basic. Again, like Maslow's hierarchy of needs, we've got to cover that baseline before we then go up and provide adaptive strategies. North's and Profound's article in 2013 with Townsend support are really, really interesting articles if you want to go on and read a lot more about these sort of different things in the background that affect someone in a disaster context. So looking at triage now, and this applies to both the disaster context and also to a normal triage environment. Now I'm going to make an assumption that everyone now understands the basic principles of triage, and the big thing that changes here is the threat level to yourself and others, and then also what sort of observations this patient might require. So that's the other factor that you put in addition to if you've got comorbidities or other physical injuries before coming in, that will factor into your triage and whether you scale them up or down. Alright, so today I'll give you a bit of an overview of crisis intervention for mental health patients, particularly in association with what is a crisis and the two different types of crisis being maturational or situational. In the context of disaster relief, I've sort of highlighted the extra things about sort of basic needs, support networks, the fact that the community doesn't exist anymore, and so you've got to provide those things for them that otherwise we would normally have to draw on as resources to provide adaptive strategies for patients with mental health crises. However, it doesn't matter what environment we're in, our assessment tools and our triage processes and our de-escalation strategies are still the same. We've just got to consider things like confidentiality in a disaster context. On the left, you'll see a little bit of resources there, so if anything we've discussed today has brought up some concerns for you, this is somewhere to go, and a really good 24-hour translating number if you don't have access to someone in your hospital. That's available for all hospitals across Australia 24/7. And just some references, so thank you for listening today, and I hope you got something out of it.